Okay, I'm going to get us started here. Good afternoon, everyone. Welcome to today's webinar, which is the Public Health Response to Climate Change. It's the first webinar of our fall series. My name is Dr. Sherry Weiser, and I co-founded and co-direct the UC Center for Climate Health and Equity, and I'm really pleased to kick off the webinar today. To remind people, the mission of our center is to harness the expertise and leadership of the health sector to drive ambitious climate action for health and health action for the climate. The center is based at UCSF, but spans all 10 UC campuses and 5 health systems, and we have over 100 affiliated faculty. Our center also has 4 strategic work streams, so research, education, health system sustainability and policy, as well as special initiatives like our UC Climate Change and Mental Health Council. And as we launch this new webinar series, I wanted to thank very much both the UCSF Office of Sustainability, as well as the UCSF Academic Senate Committee on Sustainability for their support and contributions. So today we'll be focusing on the public health response to climate change and are really excited to hear from our close colleague from CDPH, Dr. Rohan Radhakrishna. Our next 3 webinars over this fall will touch on other topics like decarbonization in healthcare and climate change and health education. And we're going to be recording all of them and sharing the recording with all registrants. And we'll be sending out registration details for the remainder of the webinars in the near future. So it's now my pleasure to introduce today's moderator, Dr. Katie Brooks. Dr. Brooks is a faculty in the Department of Hospital Medicine at UCSF and works clinically at ZSFG. She is a member of the Senate Committee on Sustainability, where she has served as the co-chair of the subcommittee coordinating the speaker series with our center. Dr. Brooks has also worked in the San Francisco's Department of Public Health's Information and Guidance Department, where she served in a clinical policy advisory role for the local health officer throughout the pandemic. She also serves in several medical education leadership roles and also has strong interests in health equity and climate and health. And I will now turn it over to Dr. Brooks.
Thank you very much, Dr. Weiser, and thank you all for being here today. I have been really looking forward to this conversation. I now have the distinct pleasure of introducing our featured speaker, Dr. Rohan Radhakrishna. Dr. Radhakrishna was appointed by Governor Gavin Newsom and confirmed by the California Senate to lead the Office of Health Equity within the California Department of Public Health. He serves as Deputy Director, Chief Equity Officer, and Tribal Liaison. Dr. Radhakrishna studied medicine and graduated from UCSF and UC Berkeley's joint medical program, which is near and dear to my heart as I teach second years at the JMP right now. He spent 10 years as a family physician in the community safety net clinics at a local health department and has served as co-chair of the Health Equity Committee at the California Conference of Local Health Officers since 2019, deputy health officer for Contra Costa County since 2018, and chair of the Department of Family and Adult Medicine from 2015 to 2019. His experience responding to the COVID-19 pandemic, power shutoffs, wildfire smoke, and heat emergencies has solidified his commitment to addressing the overlapping public health crises of climate change and structural racism. Dr. Radhakrishna brings a global perspective to California's diverse population, having lived and worked abroad in Ecuador as a Fulbright scholar, in India as a Rotary ambassador, and as a public health consultant with UNICEF and the Norwegian Refugee Council. Dr. Radhakrishna is also a dynamic and engaging speaker, and we are so excited to hear his talk today. Today, he will be supported by Dan Wu, team lead of the California Department of Public Health, Office of Health Equity's Climate Change and Health Equity section. He leads cross-sector collaborative efforts to advance California's climate policies, planning, and programs that promote public health and equity benefits. Before I turn it over to them, I want to encourage all attendees to put any questions in the Q&A. We will have a few minutes after the presentation for discussion. And now, without further ado, Dr. Radhakrishna.
Thank you so much, Sherry, Katie, Dan, Sapna, all from UC and the Department of Public Health for kicking off this fall series. My name is Rohan, and I stand for love, for dignity, and for transformation for myself, for all of you, and for all Californians. I'm so excited to share our work at state and local public health and how we respond to the climate crisis with action, with urgency, and with hope. And so as you can see on this title slide, we have the subtitle, Action, with urgency and hope. Climate change is no longer something of the future. It is happening now, and it is harming people's health. The window for action is short to prevent worsening impacts. Even 1/10 of a degree of warming matters because preventing that can reduce suffering and lives lost. Climate change is a threat multiplier. It deepens existing inequities, and it's also a huge opportunity to improve health because the actions that we take to address climate change can also improve health and equity. Change is such a normal concept and it seems so innocuous. So let's call it what it is, which is a crisis that warrants more attention and resources. My takeaways for all of you are really in the subtitle: action with urgency and hope. Many of you are dedicated to research and education, and that is necessary, but it is not sufficient. We need action from all of us within our spheres of influence, and we need to do so with urgency. We all have the potential to be climate leaders within our organizations, our clinics, our universities, our collaboratives. It takes collective action. And finally, with hope. The data, the stories, the impacts can bring despair. Action is the antidote to despair, so let's collectively do this work with the spirit of hope. I want to start by engaging all of you in a Slido poll to learn what you are experiencing on the ground in your research, in your clinical encounters with Californians. So please pull out your phones, drop your forks for a moment, and scan that QR code, or you can go to slido.com, #climate2023. The first question, and we'll give you about 30 seconds to go ahead and answer before we share the results on screen, is: are you seeing climate change affecting the health of your patients and communities? Go ahead and take a couple moments, scan that QR code, and let us know what you're seeing. We'll give you 10 more seconds to scan in and respond to if you're seeing climate change affecting the health of your patients and communities. So let's go ahead and toggle and move to the results. So we're seeing a couple dozen respondents, and about 95% say yes, 7% say unsure. That's great. So we want to learn more about the ways you may be seeing that. And for those who are unsure, we hope at the end of the talk, there may be some touch points that you become aware of, that you scan for in the environment and the literature, in the research communities and in the patients that you're seeing, to see how it may be affecting those around us. Let's go ahead and move to the second question for Slido, which is: what health issues are you seeing affected by climate change? So this is open-ended. We'll see a word cloud in a moment. You can scan again the QR code in the top left, go to slido.com, #climate2023. We see lots of participants typing, so go ahead and enter: what health issues are you seeing affected by climate change? We see extreme heat, asthma, COPD, respiratory conditions, respiratories getting bigger, allergies, quality of life, flooding, mental health, anxiety, sadness, foodborne illness, cardiovascular, fatigue, stress, air quality, birth outcomes, year-round allergies, vector-borne illnesses, wildfire smoke, food insecurity, displacement, poor mental health, diseases, poor air quality, heat exhaustion, extreme heats getting large in the center of the word cloud, disproportionately affected BIPOC, Black, Indigenous, and people of color, poor judgment at work, sleep deprivation, PTSD, post-traumatic stress disorder. I'm noting several in the mental health category that's clustering around the center as well. Not something that the literature has dove into deeply, but is an important domain. And it looks like you all are seeing it. Pesticide exposure, inequity. We'll give you 20 more seconds. We see a few more people typing, but I just want to name that we're definitely seeing extreme heat, respiratory, and mental health emerging as three big themes from your all's experience. So we'll get a screenshot of that to capture for posterity, and now move to some level setting. So before I talk about the public health response for the climate crisis, action with urgency and hope, I'd like to talk about some definitions. We throw around a lot of terms when we do health work, equity work, public health work, and I want to ground us in some definitions. Not all of us have maybe studied public health, or even for those of us who have, there's a variety of definitions out there. So I really like the Institute of Medicine's definition. Public health is what society does collectively to assure the conditions for people to be healthy. It's told that 2/3 of what affects a person's health may be outside of the clinic, outside of the genetic code. It's those social, environmental, behavioral causes set by the conditions that lay the groundwork for health as well as disease. Health equity, this comes from the origin of the office that I lead in California Code, from the Health and Safety Code statute, are efforts to ensure that all people have full and equal access to opportunities that enable them to lead healthy lives. With an emphasis on the all, I serve the Newsom administration, whose slogan is a California for all, which is really an equity mandate to leave no group behind and to close disparity gaps. And racial equity, this definition comes from the American Public Health Association, is what would exist if society no longer assigned advantages and disadvantages through institutions, policies, practices, and cultural beliefs based on a person's skin color. Racial equity looks at the root causes of inequities, not just the manifestations of inequities themselves, and focuses on restructuring those institutional policies, practices, and cultural beliefs. To achieve racial equity, we must address injustices caused by racism and support actions at all levels. We're going to end today by asking what actions you all can take within your sphere of control for health, for racial equity, and for climate action. So no matter the level that we exist in, we have access to the levers of power for institutions, policies, and practices, whether it's a university or a health clinic or hospital. Next slide. When we talk about climate work, there's these concepts of mitigation, adaptation, and resilience. And before I go through the definitions, I want you to think about that 15-minute encounter with the provider, whether you're the clinician, like I am in my family practice, or whether you're the patient, and what all takes place. It's almost magical what can happen in 15 minutes. There needs to be some mitigation of chronic conditions, of acute conditions, interventions that take place to decrease the scale of the threat on the human body. There also needs to be adaptation, lifestyle modifications, behavior changes, healthy nutrition and exercise, mindfulness, dealing with stress to adapt to some of the conditions that may be outside of our control, to maybe have less severe impacts of a chronic disease or a communicable disease. And then there's resiliency, being able to weather the storm into the future with the multiple onslaughts and the cumulative effects on a person's body. All that takes place in 15 minutes, right? Healthcare maintenance, cancer screening, immunizations, dealing with acute chronic conditions, mental, physical health. I can recall seeing 20 patients in a day in a full day of family practice. And the same is true when it comes to addressing the climate crisis. We have to simultaneously do mitigation, adaptation, and resilience. So let's ground ourselves in those definitions. According to the US EPA, mitigation is actions limiting the magnitude and rate of future climate change by reducing greenhouse gas emissions and/or advancing nature-based solutions. Adaptation, actions to prepare for and adjust to both the current and projected impacts of climate change. And resilience, the capacity of an entity, an individual, a family, a community, a neighborhood, a health system, a long-term care facility. The capacity of any entity to prepare for disruptions, to recover from shocks and stresses, and to adapt and grow from a disruptive experience. I like the positive frame on resilience. There's a whole field of post-traumatic growth that can take place from these stresses. And in that spirit of continuous improvement, as we face multiple and overlapping threats and crises, resilience is so important at the individual and community level. Next. So I'd like to take us back to Rudolf Virchow, some call the father of pathology, who really was a budding social epidemiologist and wrote that medicine as a social science, as the science of human beings, has the obligation to point out problems and to attempt their theoretical solution. The physician, which we can read as the health practitioner or even the health scientist, as I know we have a transdisciplinary audience with us from students and pharmacy and nursing and medicine and research. So health scientists and health practitioners are the natural attorneys of the poor, and social problems fall to a large extent within their jurisdiction. Sometimes we're told social issues, equity, climate change, it's not in your lane. You're a hospitalist, you're a direct service provider, you're a researcher, it's not in your lane. But we're here to acknowledge that it is in our lane. And in fact, it is our obligation to point out, like 93% of you said, that it is impacting the health of patients and communities. And you're seeing that impact right now. Next. We have to look at history and note that the legacy of structural racism is overlapping, creating cumulative burdens, impacting with environmental health justice, as well as climate justice issues. I live in Oakland and have the fortune of living in a green line zone, but decades ago, racist governmental policy led to segregation, a gap in intergenerational wealth formation by denying housing loans to certain communities. And you'll notice the red-lined areas are those along the freeways, near the factories, with the higher burden of pollution, chronic disease, asthma, particulate exposure, and the urban heat island effect with blacktops as well, fewer trees. So you see the legacy of pollution and prejudice, and it is our role as health leaders and learners to name these historic injustices, to apologize for them as participants in medical institutions and in government, and to redress them over time through data, through action, through reparations and other means. The legacy of redlining is affecting the disproportionate impact of climate on some more than others, and has to be something that we take into mind when we operationalize equity through distributional equity and procedural equity to undo the historic intergenerational effects. Next. So many people have woken up to the reality of the climate health crisis. The United Nations Secretary General called climate change a code red for humanity. And what I want us as the health field is to mobilize and collectively call for a code blue. I recall that overhead projector announcement on the speakers, code blue, ICU, room 7, rushing to that room with a sense of urgency and hope to be able to try and save a life and undo the impact of someone losing the ability to breathe, doing the intubation or getting the life-saving medications as quickly as possible. Well, the same is needed for our planet. And many health organizations and associations have woken up to this reality. In 2021, more than 200 medical journals published an unprecedented joint statement warning that climate change is the greatest threat to global public health, and that we must take urgent action to avoid catastrophic harm to human health. In June of 2022 in Chicago, delegates from the American Medical Association voted to adopt a new policy declaring climate change a public health emergency and to develop advocacy priorities and strategies to decarbonize physician practices and the health sector more broadly. And in November, they went further to adopt a policy calling for carbon neutrality in the health sector by the year 2050. Within the Newsom administration, combating the climate crisis has always been a top priority, and I'll go into more details around some of our administration's plans and actions. Next. Right now in California, we are experiencing this crisis. Even this day, September 20th, 2023, when my kid's soccer practice was canceled yesterday due to an air quality index that was unsafe due to wildfire smoke. It's affecting us now, and it's overlapping, and it's all seasons. Last year, we suffered through a record-breaking 10-day heat dome that led from drought into more than a dozen atmospheric rivers with flooding that cost dozens of lives and had far-reaching impacts on health and human well-being. We saw coastal communities facing the threats of sea level rise with ongoing coastal flooding and erosion. And we noted that of the 20 top largest wildfires in our state, 11 have happened in the past 5 years, worsening a variety of respiratory, cardiovascular, and other conditions. And as I mentioned, as we speak, in Oregon and Northern California, wildfires are affecting the air quality index right now. Public health supports creating those guidance documents about how to be safe if you have a sensitive condition, when to go outside and not, and ways to mitigate the impact of wildfire smoke, as well as many other climate threats on human health in partnership with local air quality districts and many other multi-sector partners. Next. Many of you know, and in the word cloud, heat came to the center, appropriately so, because of all the different climate hazards. It is the greatest in terms of the impact on human health that we can measure. And we're still not very precise in our measurement. Beyond heat-related illness, HRI, and the ICD-10 codes and dehydration, there is an overall increase in mortality, cardiovascular disease, respiratory disease. Heat can increase ozone production that can worsen chronic obstructive pulmonary disease. You get exacerbations in mental health conditions, adverse birth outcomes like preterm birth, low birth weight, and stillbirth, impacts on the liver, kidney, gastrointestinal system, diabetes with fluctuations in insulin, as well as many medication interactions, diuretics, ACE inhibitors, atypical antipsychotics, just to name a few. The takeaway is heat has many health impacts and creates a tremendous burden that we're still trying to get more precise in our surveillance to measure the impact of, but most importantly, to be able to prevent. Next. Hot off the presses, just last month, our office and department published an analysis of excess mortality from the September 2022 heat wave. So modeling shows that by 2050, we will have more than 11,000 excess deaths in California alone due to extreme heat. And we lost about 400 Californians' lives due to that 10-day extreme heat period. That's 5% more than we would expect due to comparative periods. And most importantly, it wasn't just older adults or the young. We noted working age adults, aged 25 to 64, had the highest rate ratios, as well as Hispanic Latinos and those from the Southern Coast region that may be less acclimatized and may have less cooling options. We noted that the health impacts of heat were not felt equally, and that those who are medically vulnerable had the overlapping effects of heat worsening some of their chronic conditions. This is the type of collaboration we hope to engage with all of you to get to the bottom of what are the preventable risk factors, who's at greatest risk, and how can we improve coordination and communication from health to public health to cross-sector to save lives. Next. We know that there are overlapping conditions, and recently UCSF researchers published on the impact of wildfire smoke on a different condition, a fungal-borne spore, coccidiomycosis. You may have heard of valley fever, first noted in California's San Joaquin Valley, but due to climate change, it's spreading. That whiplash between drought and heavy rainfall, spreading the spores to coastal and urban parts of the state. And you could see that research findings showed that the coincidence of large wildfires led to an 18 to 22% spike in invasive fungal infections. And here's where you see the overlapping between a communicable condition, chronic conditions, and environmental changes caused by the climate health crisis. There are so many, from mosquitoes, tick, fleas, water, food, spores, soil-borne, Vibrio, Salmonella, E. coli, just to name a few. And this is ripe for a lot of research and a lot of action. Next. So in classic public health textbooks, you'll see the epidemiological transition from last century with water and sanitation and immunizations and vaccines, how the overall cumulative burden on society, whether you're looking at premature death or disability-adjusted life years, decreased for communicable disease and increased for chronic disease. Well, what I call the third CD, or climate diseases and disabilities, is that force multiplier of communicable disease and of chronic disease. It can be overwhelming and complex to tease out those variables, but it means we need action, research, policy change at all levels to decrease the impact of all three, but in particular of climate being a magnifier of communicable and chronic disease. Next. This image from the Center for Disease Control was adapted by our team to add that pink ring of mental health impacts. As you all said, you're starting to see the mental health impacts in your own practice and communities. Pick a color, any color, and we could spend an hour having a discussion on the impacts of health and action steps that we can take between healthcare and public health to decrease the burden, whether it's air pollution and allergens, heat, drought, environmental degradation, displacement, wildfire smoke, change in living conditions, vector-borne ecology, food systems, severe weather, and water quality. All of these are ripe for collaboration and research. The data will show us who's most vulnerable and what are the greatest impacts, so we can focus our limited bandwidth to have the greatest impact. The next slide shows you another schematic model looking at how the upstream causes like extreme heat, flooding, and tick-borne diseases can lead to disproportionate exposures and health outcomes. And most importantly, on the right, you see the green box about the conditions. That's where public health really strives for PSE, policy systems and environmental change, to change the conditions, to allow for more adaptation and resilience to decrease the overall health burden. The next slide shows us how this has a tremendous cost, not just to human health, but also to our economy. In fact, just the impact of extreme heat modeled into 2050 has a $50 billion price tag when you add up premature death, medical care, rehabilitation, home health, medications, lost wages, productivity, and the downstream health costs like displacement from flooding or wildfires that can leave people without homes. This is tremendous and an area of additional research. We're very happy we just hired a climate economist to help quantify the lives and dollars that we can potentially save. So welcome, Maithili, to our team. The next slide shows how, with climate change, people who are facing inequities, historic inequities, unjust and preventable inequities, are hurt the first and hurt the worst. This is much like what we saw with COVID-19, those with crowded living conditions, with fewer worker protections that had to survive and didn't have the fortune of virtual work, honored for those who are working outdoors right now on our farms, harvesting amongst the wildfire smoke we're experiencing, that these multiple threats harm some more than others, which is why we particularly do our work through a health equity and a racial equity lens. The next slide shows how we want to tell the story of the lessons learned from the COVID-19 pandemic, and we invite you to join our Climate Action Team Public Health Work Group. There's a recording in a YouTube link of our November 2021 session where we took a deep look at lessons learned from the COVID pandemic and how we can apply those to the climate health crisis. And happy to engage more on this important topic so we can learn from history to have more coordinated responses to save lives. But I do want to share a few quotes that were shared at that session, naming racism, not race, as the risk factor that contributed to the rapid spread of COVID amongst community of colors, and how racial injustice and climate injustice are both rooted in the evil notion that some lives are more important than others. I can't breathe were among the last words uttered by George Floyd and Eric Garner, and became a rallying cry for racial justice in recent years. I Can't Breathe captures the impact of someone suffering from SARS-CoV-2 virus, intubated, prone, perhaps unable to breathe their last few breaths and talk to a loved one. I Can't Breathe describes the overlapping environmental injustices and disproportionate impacts of air pollution from red line neighborhoods, from the urban heat island effect on communities and low-income communities of color, and is really that rallying cry to issue a code blue for humanity, for the health sector to help lead this threat to planetary health and to people's health. The next slide shares what you all called out, which is the mental health impacts are increasing. We need to study it and talk about it more. So I'm so glad that there's a subcommittee council focusing on it within California. This schematic from the American Public Psychological Association, Eco-America, shows that Venn diagram overlap of physical health, mental health, and community health. And most importantly, that yellow circle in the middle where we can affect the conditions to minimize the vulnerabilities. Those headline quotes talking about climate anxiety, which has a specific definition, a chronic fear of environmental doom ranging from mild stress to clinical disorders like depression, anxiety, post-traumatic stress disorder, and even suicide is increasing. We're measuring it here in California amongst youth. And we know that those who have existing mental health conditions are more vulnerable to the impacts of climate change, not just due to access challenges or medication interactions. And in and of itself, if you look at something like extreme heat and wildfire, they can independently contribute to post-traumatic stress disorder, grief. With hotter temperatures, especially at night, you see an increase in intimate partner violence and gun violence and suicide. So these are things that we need to look at to destigmatize and to mitigate as a healthcare community. The next slide shows our potential because a health frame motivates climate action. For the first time, Americans are more motivated by health than by jobs as the #1 reason for climate solutions in America and in California. And 68% of Americans trust health professionals for information on climate change. You can see on the right with members of Congress and car salespeople at the bottom, we have to leverage the trust that we have. Nurses at the top of health professionals that are trusted by America at a time when trust is very low in government. It was 75% in the Eisenhower era, and it's 25% right now, according to Pew. In order for the public to trust health and public health interventions, we have to build trust, and we have to bone up on our climate knowledge and action steps that our communities, our practices, and our patients can take. And we are the people to do it. If not us, there are fewer people who are trusted than health professionals. The next slide shows another important frame for you all to be aware of, which is called One Health. It's the idea that the health of people is connected to the health of animals and our shared environment. As part of modernizing our public health workforce in California, we hired a veterinarian, Dr. Kim Conway, to lead our One Health office. As you can see in the bottom right, there's communities of practice at the local, national, and international level, and our team is helping fill the gap through a statewide collaboration. We invite you to reach out to Dr. Conway to learn how your communities can join these networks. And I want to share the examples on the far right about how a changing climate can affect our health. Wildfire can displace animals, leading to hazardous air quality and disrupting the human-animal bond during emergency evacuations, and lead to the migration of people as well as pathogens. We're going to see global displacement and dislocation from refugees and displaced humans as well as animals, viruses, and pathogens. And so there's a direct link there. Hurricanes can lead to an increase in zoonotic diseases, leptospirosis. We're seeing concerns for Vibrio, not just looking at the flooding in Libya or in the eastern United States. Warmer weather can expand tick habitat. Drought can lead to increase in food prices, can lead to decreased food security, can lead to worsened chronic conditions and diabetes and metabolic syndrome. Migration, I mentioned, and algal blooms can harm our pets as well as our own health. So just a few examples of the close interrelationship. And I like to invoke the